I just needed to ask you, with all this complexity of teams traveling in and out to be able to evacuate patients from remote locations, how would you secure the safety of medical staff who are involved, not just in the retrieval process? How would you talk to them? How would you motivate them? And how would you look at taking care of them, not just during the surgery, but also in the post-transplant setup in the ICU?
Listen, motivating isn't such a difficult thing because the team, like yourself, this is what we're there for. I mean, this is something we do every day. They're engaged by the fact that they have patients who need to be treated and saved. Their lives at stake. And, just that example of a 23-year-old, could be 33-year-old, 45, 53-year-old, doesn't matter. The point is they all are not just individual, but attached to relatives, families, loved ones. This is what we do, whether it was lung transplant, heart transplant, anything we do. So the team is sold. And we actually, so it surprised me that even those that when we're trying to be most careful about this infectious status, we seem to just throw ourselves into it. And the nursing staff. I mean everybody, allied health, everybody. It does whatever, and I've had arrest situations in highly infected COVID patients. And now remember that those ECMO patients or those ventilated patients who are being transferred for tertiary care in a timely fashion are still in their infective phase. So you've got the worst infective patients. And when the arrest happens, you'd be surprised how little PPEs and things are possible to put on if you're doing CPR and trying to put ECMO into these patients. So it is all you can do is to thank everybody. Say, next time, let's try and get better. How can we, foresee this? What can we do? So it's an evolving thing. But of course, you're absolutely right. That we try and limit the number of people that are involved in all of this. We try and separate out the teams if we can so that the team that's retrieving doesn't have to then come and take part continuously for the other parts of it. We need to separate out the teams and the nurses, the physicians and nurses team, including the cleaning team and so on, that is involved in the areas where there's potential of infection. So this majority of hospitals are very good at. Where manpower becomes short, you have a real problem because you only need one person to cross or abuse that barrier to then spread. And as you and I know, then our healthcare workers, staff, colleagues have become positive and have had to go and isolate. And sadly, a few have required to be in ICU, and even sadder, even fewer, thankfully, but nevertheless tragic that they have lost their lives amongst our own colleagues. So this is happening all the time. But in the context of so many more lives that are lost every day unnecessarily because untimely referral and also practice itself of the medicine in that Unmil mentioned, he's mentioned tocilizumab, all sorts of other things that we use, plasma therapy and so on, unevidenced. In fact, the general message is don't use these things. If you do, there's a certain time, remdesivir, that you can use. But you find majority of hospitals throwing the whole bucket at every patient unnecessarily and sadly, often increasing the risk of infection, particularly with the higher doses of steroids. And we've seen this resurgence of fungal infections in patients, which becomes a nightmare postoperatively if you get mucormycosis, or supposedly called the black fungus. So, the other thing, of course, is during the surgery, again, you have to be absolutely careful about where they are in their disease status. And Unmil is, again, he's mentioned, this is critical, to know when the patients start becoming symptomatic. So normally, if you're symptomatic, and you're not in a hospital setting, you can go home and isolate you for 2 weeks. You don't actually need to have a repeat test as such, because you're considered by then to be free of being infective. The same thing applies even to a critical patient after 3 weeks. So what we've done is to say, well, let's go from the time of, recently was to go from the time of the RT-PCR that was positive, and let's give it 3 weeks from there. It's a critical patient, which takes you up to 28 days anyway, and then they are definitely non-infective, right? So you can treat them as such. And what's also not happening is the patients are not being considered to be moved out. They're being left on the COVID ward in many places when they shouldn't be. They should be moved out. And of course, a positive test at that point often is meaningless. It's often a false positive, and people aren't looking at other things that you can look into that test to see whether or not, in fact, it's likely to be a positive test or not. There are clues there that you can glean from the PCR test. But assuming if you think the patient is still positive, then of course you've got to be very careful about your surgical team, limiting the number in theaters and in the ICU, making sure everybody's got their appropriate PPR for that setting. And of course, not forgetting that the donor has become an issue now, because majority of donors are likely to be also have a risk of becoming positive. And we've had that. We've had donors who at the last minute who may have had a negative nasopharyngeal swab, but we are absolutely have been determined to say, no, we want a deep lung samples with a bronchoalveolar lavage, which you do with a bronchoscope, a flexible bronchoscope, and those have come back positive. And so you have to abandon that using that donor, because you're going to put everybody at risk, not just your staff, but most importantly, the recipient. And this has happened, of course. It's been written. There's been a case in the States where the donor ended up being positive only retrospectively known, but the surgeon and the team were then positive and had to isolate, and thankfully they were okay. But so this is just again comes down to teamwork, and you can't achieve this level of safety for your staff and colleagues without having the teamwork. As long as you're in a team, it keeps you within the discipline. And I think that's really crucial. And you and I couldn't do our work without teams.